بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Our presentation today is mainly practical. It is about our practical peerless and smart strategies in glaucoma and anterior segmenting. Mainly, we have a lot of groups of ophthalmology, and we are hearing a lot of complaints from our colleagues about their routine examinations, and how there's a lot of complaints about the examination. So my main aim today is just to share my experience, and with your experience, of course, we can refine our techniques on how to do and how to deal with the patients, especially for anterior segment and glaucoma patients. So from the beginning, when we are dealing with a patient, we have to make a scheme for our examinations, starting from the history. You know, some patients, when they are coming to you, they are sitting on the chair, they are telling you, examine me. And at the end, what is your complaint? No, please examine me first. What is your complaint? Please examine me first. You have to be firm with them. The first thing is you have to complain first. This is the first thing. Don't just rush to the examination. You will like you're examining you. No, you are not examining me. You are coming to take my advice. So you have to follow our routine and to follow the what is written and what is our scheme for the sheet for every patient that come. First is your complaint. So complaint, history, and then visual acuity. You have to make sure that the visual acuity is taken. I remember when I was in FRCS examination, it was a very minimal mistake that he told me just examine the pupillary reactions. So I examined the pupillary reactions. It is not coming to any. It is not AD. It is not anything. There is a maybe afferent pupillary defect. So I told him I need to examine the fundus. And when I told him he need to examine the fundus, he told me why. I told him I think there is something. There is an optic problem here. So I examined the fundus. So I examined this is an optic atrophy. So he told me. I told him this the patient is blind, so there is no pupillary defect is already afferent pupillary defect both eyes. He told me this is because you didn't tell the patient if he was seeing the light or not. Very single and simple thing. You are seeing the light or are not seeing the light. This is just the beginning, not going to jump to the examination. So we are not jumping to the examination. We have to follow our routine steps. Okay. So slit lamp examination, the IOP and gonioscopy, and then dilated fundus examination, and then we will take the plan of treatment. So this is the step-by-step approach to our patient. So the slit lamp examination, we have to start from the, not from the cornea, from the lens. Just go to, even you have to adjust your slit lamp, to go to lower magnification, examine the eyelids, then go to the cornea, anterior segment, iris, lens, then fundus, and then the gonioscopy. If you can do the gonioscopy. If the lens, you can see through the narrow pupil, it's good. If not, you have to dilate. So this is our routine.
Here we are cleaning, putting the chin rest, separate paper for each patient and remove it. If we have a case of viral conjunctivitis, we are telling my assistant that we have a viral case, so she will clean after we see the patient. She will clean everything that the patient touches. Even here, as you can see, even the chair.
So why is this? Because you know the problem with these cases that complain from that you touch my eyes, you didn't wear gloves. We have heard a lot of complaints about this, that the patients make a complaint in MOH that the doctor examined me without wearing the gloves. So how we can deal with these patients and how we can protect ourselves and protect from this complaint. So this is the examination. From the time of Corona and even before it, I am not examining any patient without wearing the mask. Okay? And the shield already present on the slit lamp. The idea here is the cotton bud, not to touch the patient, just hold the cotton bud in your hand, okay? And whenever you're going to touch, open the eyelids up and down, you can just use the cotton buds instead of using your fingers, even if you are not wearing the gloves.
So we are not touching the eyelid. So this is the when we are going.
So say 90 degrees, even 90 degrees, we are not opening the eyelids, just the forehead rest. We are touching by our fingers on the forehead rest. So this is like a fixation point. You are fixating by your fingers and holding the lens like this.
With our fingers to rest on the forehead rest. So also we are not touching the patient. So this is our.
For the left hand, we are using the little finger. If we are touching, you are just putting the little finger on the forehead rest. The plastic, this plastic. So the distance, you can adjust the distance of the 90 diopter with the fingers. If you don't have an armrest, you can use the tray, the rack of the slit lamp. Just put your elbow on it, so your hand will be fixated. Okay. So at the end, we are not touching the patient. So if he complains or if he is saying that you touched me without wearing gloves, I didn't touch you at all. All my examination is away from your body. Okay. The tonometry, we have the gold man, this is the golden standard, but for our busy clinics, we can use the tonopen, eye care, and myself, I find the tonopen, the eye care is the most suitable, especially for children. It's very fast, you can just use it even without anesthesia. This is the eye care. Once you have the green light, this means that you are in the correct positioning, so you can measure. The tonopen, look at the sleeve how we are putting it, because there is a problem with measurement with the tonopen. Fine corrugation at the tip. If you have the fine corrugation, this you are right. If you don't have it, this means
overstretch like this. Overstretch. This is not good. Okay. So always have this fine corrugation. If it's loose like this also will not measure perfectly. So always make this adjust it until you have this fine corrugation. So you can measure now accurately.
This is a very important thing. Now, for those who are doing cataract surgery, we have a lot of problems now with insurance companies about the slit lamp photo. And they are asking for slit lamp photo for diffuse and slit lamp. And some clinics, they don't have the slit lamp camera. So this is a very simple approach that you can take the photo. And this is, if you have the QR code from AliExpress, you can get it by something like 100 riyals. This is a camera with an adapter to put it on the slit lamp. Look what we are doing. This is a magnet. And this string, you can adjust it to the eyepiece. So either to the computer or directly from the camera you can take the shots. Oh. Look, the adjustment. Go to the dimmer, not the brighter beam, and try to decrease the illumination. Because if the illumination is bright,
So first of all, we have to make the light on this, not the highlight in the dim one. Okay, and also we'll make it slightly dimmer. Brighter. We'll have the reflection of light. Okay. Once we finish, you can just take video. You can take.
so this is how to overcome this problem with the insurance companies. The other thing, I talked about it in the last presentation about the algae brush. And this is for any polyclinic that we have any corneal foreign bodies. So this is the algae brush.
So you can clean, and when you are working on this system, just this is now stop, now clean, work stop.
By your finger, when you are cleaning the rust, just by your finger you can operate it on and off by the finger only, as you can see. So you can clean the rust without using the needle, and this is very easy and very efficient in cleaning the rust ring. If you don't have it, it's better to have it because this will save your time and save a lot of problem with the patient. And this is a video how it is work. This is cleaning the main foreign body with the needle. And then you have the rust ring. So you will use the algae brush to clean this rust ring. You see, it is just like it as a diamond pearl, so just so once operated, it will just clean this rust ring without leaving anything behind. So this is very easy, very efficient, and you will save the time on the patient, and as you can see, it is clean. Now we have the problem with corneal abrasion, especially with the children. They are coming to you like closing their eyes, and they are crying. My kids is just scratch the eyes of them. So don't be afraid once you feel that this is a corneal abrasion, clean corneal abrasion, there is no infection. So just stain, show the patient that you stained it, even they can take pictures, okay? As you can see, it's a very big one. The easiest way and the safest, just put a bandage contact lens. Don't put patch. Patch is, he will still feeling pain and he will go to another clinic and he will search around still because he's still feeling the pain. So just once you put the bandage contact lens, the patient will burn, suddenly he will feel just, I'm relieved, okay? As you can see, this is the bandage contact lens on the slit lamp, and this is how to put the bandage contact lens. Don't use your fingers also, it's the same. Okay, we are using the micro sponge. Okay, get it by the micro sponge. Open, look down, okay, and just put it by the micro sponge. You didn't touch the lens at all, so it is clean, sterile. You didn't be afraid from any bacterial or any contaminations that happen to the lens. Leave it for 2-3 days. Once it is healed, just take it off. And when we are going to remove it, also we are not touching. We are not taking it by our fingers. You know, all females are just like taking it out like this. Even if you are wearing gloves, they will squeeze while you are taking it. Just put a binox by your forceps, tight forceps, and just take it out. Cotton bud is the upper eyelid, okay? So cotton bud, forceps, and micro sponge. Just you will not touch the patient at all. As you can see, we take it out by the forceps and that's all. So you are
Touch the patient.
be 100% away from any contaminations that will happen to the patient. The gonioscopy, it needs a slight learning curve, but once you master it, it is very easy. You have to make the magnification high, and you need to make the beam shorter, okay? And when you are seeing any angle, just make the beam to the opposite of it. If you are seeing the nasal, make the beam temporal. If you are seeing the temporal, make the beam nasal. So this is for gonioscopy. If the patient coming towards glaucoma, we are seeing the optic nerve, we are seeing there is an optic nerve cupping, we need to make the glaucoma work up, okay? The glaucoma work up consists of 4 main things. The first is fundus. Document the fundus image, okay? You will see it and you will show it to the patient because what is the cupping, what is the pallor, what is this? He will be asking you. Then the pachymetry, okay, in this, if you have a sham flow camera, you can get the iris configuration and slit and the AC depths. Then the OCT, and make sure that the OCT signal is high and there is no artifacts. And the visual field. Visual field has to be correlated with the optic. All these tests has to be correlated with each other. If you have a cupping without with high IOP, but the visual field and the OCT are normal, this is ocular hypertension. Okay? Even we are not giving, I have some patient with 28, 29, and we are not giving them any medication. So whenever I have the patients that have high intraocular pressure, make sure that this is glaucomatous, not ocular hypertension. Okay? If he has any defect, don't rely only on the visual field. You have to correlate this defect with the visual field thinning, with the OCT thinning for the nerve fiber layer at this area, with the opposite area. If it is superior, it has to be inferior thinning of the nerve fiber layer. So we have to correlate the whole 4 tests to diagnose a glaucoma patients. The programs, it is if the it's advanced glaucoma, we can do the macular or the 10-2. The regular is the 24 or 30. The fast is the best, is 3 minutes instead of 20 minutes, so you can do it regularly for your patients. You have to look at the indices, the reliability, if there is false positive or false negative. If there is false positive or negative, don't depend or rely on this test. So, as we said, we have the glaucoma suspect, we have the ocular hypertension, we have the glaucoma, either open or closed angle, and we have the advanced or end stages cases as the visual field and OCT of the previous patients. And the decision will depend on this, how to deal with them. For our glaucoma patient, once we have the glaucoma, we have to put our plan. Either we will start by the medication first, and the first line is prostaglandin analogs. Okay, we have our sponsor today, Tamar. They have the Travatan, and this is prostaglandin analogs. Okay, equal to it at the same line is the SLT. SLT now is considered one of the first line as the medication. If the patient cannot tolerate or uncompliant with medication, we can jump on directly to the SLT. Okay. I will just go because we have a shortage of time, and we are asking about this a lot. The glaucoma with pregnancy. How I will deal with a female which is pregnant and she is taking medication and I cannot do surgery, and what medication I can use for first trimester or second or third, and if it is lactating, how I will deal with this patient. And it is very easy, okay? So, just take a shot of this one. this is very easy and very concise and how to deal with this patient. For first trimester, second, lactating, every trimester you will have what we are going to use. So in preconception, you can take the decision at whatever you want. You can do surgery, you can do medication, whatever. First trimester, safest brimonidine. And we have brimonidine alone, or we can use it with the Simbrenza with the azote, bernizolamide. Okay. Second trimester, brimonidine can be used, but take care with beta blockers, topical carbonic anhydrase with close monitors. But still, the brimonidine can be used in first and third, and second. Third, still the same, but we can use prostaglandin analogs should be avoided at this third trimester. Okay. Lactating, topical carbonic anhydrase inhibitors, beta blockers can be used during nursing. Okay. Brimonidine is contraindicated for lactating because central CNS suppression. Sorry. So the CNS will be depressed for the babies, so they will come to you sleeping too much. Sometimes it is beneficial for the mother, but at the end, this is not the idea. Okay. So our case work is through from once we have the patient in the clinic, as we said, history, diagnosis, examination, and go to the imaging, put our plan of treatment, the management, and to check the IOP and document whatever you see, just document it, because some of the patients are just coming to you, you didn't do that. So document whatever you see, because at the end this can protect you from any complaint later on. So just a reminder, this is our wave examination. The cotton bud, okay, to use it for the touching the patient, not to touch it with our fingers, no need to use the gloves. The BCL with the micro sponge, and use the tonopen or eye care for the IOP measurement. There is a lot of features for the glaucoma management, the diagnosis with AI, and a lot of machines now are incorporating the AI in the diagnosis. The innovation for the mix, for the a lot of mix. For myself, I find it just investment. They are just promoting something that they want to sell, but at the end, if your hands you are more confidence in your hands. For me, I am confident with the non-penetrating. I am doing it from 2003 now. It's like 22 years, and alhamdulillah, my patients, we are not needing anything, just the non-penetrating glaucoma surgery. From the second day, there is no blebless surgery. You don't need to do anything later. Most of my patients are not using drops except for late or end stage cases. We are giving them the alpha-GAN or the Simbrenza or Combigan or whatever, just a neuroprotection only. But the IOP, mostly it is in the low teens. Even they said that the physical ostomy is the high teens, but alhamdulillah, in our hands, less than this, alhamdulillah. But for mix, it is easier now for those who are not doing the non-penetrating. The easiest now is the mix, either the VersaFlow, the Hydrus, the eye stent, whatever mix you can do, it is easier and it's not taking time. The neuroprotection, we'll talk about it. Gene therapy, it is under investigation. And the remote monitoring now is there. You know, there's a lot of era now for the AI, for the robots, and they are doing their surgeries remotely by the robots. So this is my main aim today, is just to give you a brief about, because from what I heard about the complaints, this is very simple presentation. I just want to deliver this message only so we can benefit from it. And if any one of you has any techniques that can benefit us, we can just share our experience. And at the end, thank you. This is my mobile number. This is my page. If anyone wants anything, you can freely communicate with me at any time. Thank you.
I think there is no question because it is not but if anyone something to share with us.
Sir, what about ocular hypertension? Like you said, if the pressure is like 27, 28, and there is glaucomatous, like cupping is there.
Yeah.
So you said you will not treat that and will keep on follow.
Yeah, I depend on the glaucoma workup. If his glaucoma workup is normal, like the nerve fiber layer thickness is normal, the visual field is normal, okay? Only the cupping and the high intraocular pressure. So no need for medication, just follow up every 6 months or 12 months, just repeat the glaucoma workup. If it is stable, no need to take anything, even if the pressure is high.
But sir, if there is like family history is positive, or if there is only eye, or if it is like risk factors are there.
Yeah.
So, according to
You know, you can give as a protection, but at the end, I have cases like 7, 8, 10 years still on the same intraocular pressure and their visual field. I can get you the serial for them, even for the machines now. They can give you a curve for the whole test. It is on a flat line, plateau line. So at the end, it is not this pressure. There is not affecting their optic nerve. Once you have a very minimal affection, this means that you need to stop the medication. But you can give medication, you can do an SLT just to lower, but it is not a glaucoma. You have to tell the patient this is not glaucoma. We have to differentiate between glaucoma and ocular hypertension.
As regarding the corneal abrasion, Dr. Eslam, thank you very much for as soon as presentation. I also put a bandage contact lens in all the pediatrics who are coming to my clinic with the corneal abrasion, but sometimes the epithelium is a bit heaped up over the abrasion itself. So in this condition, I prefer to make some debridement of this epithelium first before putting the bandage contact lens. Otherwise, it will make very severe pain.
Yeah, of course, and I agree with you, and Dr. Eslam can tell us more about this. But these patients are those that comes to you maybe in second or third day.
Yes.
But if it is a recent, just he come to you crying, this is the best timing that you can put bandage contact lens. And in 1 or 2 days, the patient will come completely, totally healed. And just keep it for 2 or 3 days, but the main instruction I give to them, you will feel dryness in the morning. So please hold your hands, don't rub your eyes. Because if you rub your eyes, you will get a recurrent abrasion. So the main problem with Riyadh here is the dry weather. Once you are telling them, once you are waking up from sleep, your eye will be painful. You will rub, first thing that you will rub your eyes. So please hold your hand. Don't rub your eyes at least for 1 month. You will not get the recurrent abrasion.
Of course, thanks Islam for the very, very nice presentation from my side. I will explain why. After just 2 brief simple comments. Of course, what you mentioned regarding the abrasion, and Dr. Ahmed also is perfect, matching our knowledge, and as it should be in the basic practice. I enforce what you are saying about applying a BCL in the first day. Just I saw the patient, and I want to change mind of the practitioner about to apply a patch over a corneal abrasion. If you apply a patch, it shouldn't be a patch. What I mean patch? The issue when the healing is very fast, less than 24 hours. But if you don't cover the healing abrasion, it will reopen again. So the rationale behind the patch is to be a tight patch, to prevent moving the lid over the patch over the abrasion behind the patch. So if you make it loose, you don't do anything. You convert the eye into an abscess. So second day the patient will come with a ball of abscess and discharge coming from behind the patch. It don't do anything. So if you apply a patch, it will be a very tight patch to avoid moving the lid over the patch over the cornea behind the patch. This is the very important tip That's always missing in what I saw referred cases after 2-3 days starting to have a corneal infiltration because of the wrong practice. And I know many practitioners, even seniors, are afraid from putting a
BCL, yeah.
over a breast cornea. And I think we should change this practice.
And you have to explain to the parents, especially for
Yeah,
children.
exactly.
Yes,
Children and adults
that
as
the
well.
movement of the lid is the cause of pain.
Yeah, exactly.
So we have to just separate the movement from the wound. It's like you are making the separation now. If the lid is moving, this is the pain, the main pain.
Just give 24 hours or less for the healing cells just to coact. If you don't cover it, it will do. Second comment, I encourage the type of presentation. This is not basic knowledge, but this tips is very important, and I will have to enforce and cross-link our presentation up to date with very basic knowledge like this, because it's very important tips and very crucial in having the up-to-date knowledge and communication.
Thank you. And thank you all, because the dinner now, they are closing the restaurant, so you are welcome to go now because you have to stop at